So, good evening, everyone. In this today's evening CME on prostate cancer updates. So, our speakers for today needs no introduction, but still it's a formality for me to introduce our first speaker. So, our first speaker will be Dr. Sudip Das, medical oncologist, Manipan Hospital, Kolkata. Sir will be talking on reaching new heights in MSPC care. So, I am inviting Dr. Sudip Das, sir. Please present his slides.
Yeah, thanks to Bear team for giving me this platform. Yeah, so I will be speaking on reaching new heights in metastatic hormone-sensitive prostate cancer. In fact, what are the development we witnessed in metastatic hormone-sensitive prostate cancer? These are my disclosure. Now, if you follow the uh, disease, the disease spectrum of prostate cancer. So the spectrum starts with localized or locally advanced prostate cancer. And after the treatment of local treatment, successful local treatment, either by surgery or by definitive radiation, often there is a biochemical recurrence when there is only PSA is rising, but there is no as such uh, failure, obvious failure, and PSMA scan. Now, if you start ADT at that point, the patient are under control, and then after a point of time, the patient may again start progressing biochemically. However, there is no progressive site on scan, particularly PSMA PET scan. Now, these are the patients who are non-metastatic CRPC, and often there are situations when after biochemical recurrence, patients they start development of radiologically obvious metastatic sites. Now, these are primary progressive metastatic hormone sensitive prostate cancer, and there are patients there who upfront they present in a metastatic stage. They are newly diagnosed metastatic hormone sensitive prostate cancer. So, whichever is the presentation, be it non-metastatic CRPC, a primary progressive hormone sensitive prostate cancer, or newly diagnosed hormone sensitive prostate metastatic hormone sensitive prostate cancer, they all ultimately they progress in metastatic CRPC, which is a which is a terminal fate of every prostate cancer patients. And once the patient is reached in that phase, entered in that phase, unfortunately, most of the systemic therapy available for in CRPC setting that leads to an achievement of OS improvement of only 2.5 to 4.5 months. So for all medical oncologists, the most important part when we are dealing with a prostate cancer patient is to somehow delay the progression from HSPC to CRPC. That should be the strategy. So the most aggressive, most intense form of therapy and most effective form of therapy has to be introduced when the patient is in HSPC setting, which can be either a primary progressive HSPC or newly diagnosed HSPC. So this is the time when one should exploit all the best effective treatment options. This is the opportunity to delay CRPC and further improve outcome. Now there were different strategies which were proven in landmark phase 3 trials that which can delay from HSPC to CRPC, and not only delaying CRP to convert to CRPC, they also lead to ultimately a significant impressive increment in overall survival. Like this is Stampede uh, trial OS data. Survival with newly diagnosed metastatic prostate cancer in the docetaxel era. This is data from 917 patients in the control arm of the Stampede trial. So you can notice that how much is the event-free survival benefit as well as the overall survival benefit with docetaxel. Now, this is prostate radiotherapy in hormone-sensitive prostate metastatic prostate cancer. Now, Stampede showed that early introduction of docetaxel in HSPC setting improves overall survival. Even there is a role of prostate radiotherapy in metastatic setting, but with a note here, in limited bone metastasis patients, less than 4 bone mets patients, limited bone mets patients, they enjoy failure-free survival and overall survival benefit if there is less than 4 bone metastasis. Now, these are the all landmark phase 3 trials which have shown that what are the systemic intervention which can lead to survival benefit when introduced early in HSPC setting. Like Stampede is all about docetaxel, and then we have Charted trial that also showed that with docetaxel, the hazard ratio for OS is 0.72. Then we had Latitude trial for abiraterone, which the hazard ratio of 0.66. We have Archis trial, which is for enzalutamide, and Enzamate also for enzalutamide. And we have Titan trial for apalutamide, Peace1 and Arasen. These are two trials which is about using triplet. Both used ADT plus abiraterone plus docetaxel, and they have clearly shown survival benefit. So now we have ample data to support concomitant therapies. So which one to you choose? Coming to Charter trial, docetaxel in metastatic hormone-sensitive prostate cancer. Look at the high-volume disease patients. The improvement in OS in high-volume disease was 16.8 months with a p-value, significant p-value. But the docetaxel plus ADT did not translate into OS benefit for low volume disease. The hazard ratio was 1.04 and improvement in OS was there was no improvement in OS. What about abiraterone? It has clearly shown a high benefit in high risk HSPC setting. Abiraterone was the first to show that hormonal treatment can be effective. However, it is important to understand the treatment journey of the control arm when interpreting this data. Now, even if only 5 mg prednisolone in metastatic HSPC setting, what are the adverse effects of the abiraterone plus 5 mg of prednisolone? You will notice that there is more number of grade 3 and grade 4 hypertension. Because of abiraterone, there is more hepatotoxicity, like transaminitis, hypokalemia, which is grade 3 hypokalemia, was noted in 11% patients. There are some grade 3 cardiac disorders. There's fluid retention and edema, which is a known side effect of abiraterone. And we all know that steroid can cause osteoporosis and osteoporosis related fracture as well as cataract. Titan trial was the apalutamide plus ADT. progression-free survival benefit with a hazard ratio of 0.48 and overall survival benefit with a hazard ratio of 0.65. Now, if you look at the PFS benefit according to low and high volume disease, both the group got benefited with addition of apalutamide, Enzamet. The subgroup analysis has shown that the benefit of enzalutamide in overall survival is more prominent in low volume disease with a hazard ratio of 0.43. If the patient is in high volume disease, then the hazard ratio is 0.80 and adjusted p-value of 0.14, which is not statistically significant. Now, how to combine the different therapies to improve survival further? This is PEACE 1 trial. One should notice the carefully observe the study differences, subtle differences in study design. Like in PEACE 1, only de novo metastatic patients were enrolled. Patients who were earlier diagnosed in a localized or locally advanced stage and they were successfully treated with local form of therapy and there was recurrence and recurrent metastatic patients, they were excluded from this trial. High volume or low volume, all sort of patients were enrolled. The inclusion criteria was less than or up to 3 months of ADT prior to randomization, no prior cytotoxic chemotherapy or biological therapy. They are stratified according to ECOG score, metastatic sites, lymph node versus bone versus visceral, type of castration, surgical or medical castration, docetaxel, yes or no. Now, there were two arms, the standard of care and standard of care plus abiraterone plus prednisolone. But in this trial, not all patients in the standard of care arm received docetaxel. So we'll observe in subsequent slides that there is a percentage of patients who did not receive chemotherapy as standard of care. There are another two arms, arm C and arm D, who received radiotherapy along with the intervention. However, we'll mostly focus on the trials on the arms which received standard of care versus standard of care plus abiraterone. For high volume disease, median the hazard ratio was 0.72 in favor of standard of care plus abiraterone. And for low volume disease, the hazard ratio was 0.83, which was not statistically significant. This led to a confirmation that in high volume disease, you could improve outcome by adding abiraterone to docetaxel versus docetaxel alone. In low volume disease, it did not seem to be as beneficial as the high volume disease. Coming to ARASEN study design, the patients were all metastatic hormone sensitive prostate cancer and candidates for ADT and docetaxel with PS score up to 0 or up to 1. They were stratified according to extent of disease, M1A versus M1B versus M1C, alkaline phosphatase levels. And in this trial, de novo metastatic patients or recurrent metastatic patients, both type of patients were enrolled. Patients were randomized into standard of care, which is ADT plus docetaxel 6 cycles plus placebo versus ADT plus docetaxel 6 cycles and darolutamide 600 mg twice daily. Now, in this trial, the standard of all patients, they received docetaxel. The primary endpoint of this trial was overall survival. 86% patients in this trial received all 6 cycles of docetaxel. Adverse events between arms are almost identical. These are the overall survival difference. At 51 months, there was 13% increment in overall survival, 63% versus 50%. The hazard ratio for overall survival was 0.68. The median survival in the placebo group was 49 months versus, and it was not reached in Arasen, the regimen, triplet regimen. Look at high risk and low risk patients OS. In high risk patients, hazard ratio 0.71, and in low risk patients, hazard ratio 0.62. And look at the confidence interval. In both the group, actually, the OS benefit was statistically significant. Arasen's key secondary efficacy endpoints: time to CRPC, there is 64% risk reduction. Time to first subsequent antineoplastic therapy, 61% risk reduction. Time to pain progression, hazard ratio 0.79. Time to first SSE, symptomatic skeletal event, hazard ratio 0.71. So in all the secondary efficacy endpoints, Arasen's triplet regimen is superior against standard of care. Look at the PSA response and outcome at 24 weeks, at 36 weeks, at 52 weeks, or any time. The percentage of patients who had undetectable PSA is significantly higher in triplet regimen. At 2 years, at 24 weeks, almost 50% patients had undetectable PSA in triplet regimen. At 36 weeks, 57%. At 52 weeks, 60%. And more than two-thirds of patients reached below 0.2 in the overall study. This is the curve of time to PSA progression. Hazard ratio for PSA progression is 0.23. And overall survival, the undetectable PSA at 36 weeks, the median overall survival not reached, and detectable PSA at 36 weeks, median overall survival is 33.3 months. So at 36 weeks, if PSA was undetectable, then it was a good surrogate marker of overall survival in long term. Hazard ratio of 0.37. These are the percentage of patients who had undetectable PSA. PSA response and outcome in high volume HSPC. Darolutamide triplet achieved long periods of no disease progression and also significant improvements to overall survival. Look at the delaying of PSA progression. Time to PSA progression, that is CRPC, the hazard ratio is 0.20, and the overall survival in this group is the hazard ratio is 0.30. What about low volume HSPC? Even in this group of patients, there are almost double percentage of patients in Arasen's regimen, they achieved undetectable PSA. Time to PSA progression or CRPC, the hazard ratio was unbelievable, 0.09. At 48 months, that is at 4 years, almost 92% patients, they were in HSPC setting, they did not progress in CRPC, in low volume disease. Even in low volume disease, overall survival benefit was clearly evident with a hazard ratio of 0.34. So, deciding between doublet and triplet in HSPC, patient able to tolerate and accept docetaxel, because more than 80% patient in the trial, they could complete the docetaxel 6 cycles. Extent of disease, Arasens regimen has shown efficacy in high volume as well as low volume. Age and life expectancy. It hit hard and early because prostate cancer will be the cause of death. Docetaxel be an obligation in the near future. Much effective, less effective post ARPI progression, and patient needs to be informed of the options. With this, I want to thank you all for your patient listening. Thank you.
Thank you, sir. Thank you, Dr. Sudeep, sir, for your nice presentation. We'll wait for a minute. If anyone have any questions, they can ask directly to Dr. Sudeep, sir, or they can chat in. They can type in the chat box as well. Sir, there are no questions as of now. So we are moving forward for the next speaker. So if in between anyone have any question, they can type in the chat box. So now our next speaker is Dr. Pradeep Kumar Mondal, sir, medical oncologist, Manipal Hospital, Kolkata. I invite Dr. Pradeep, sir.
Please share my slides from your
Sure,
end.
sir. Sure. I'm sharing, sir. No problem.
Yeah. Hello. Make it full screen, please. Okay. So thank you, Bayer Medical team, for giving me this opportunity. Thank you. And thanks all the respected colleagues who have joined in this academic evening. So today my topic of discussion will be advancing metastatic HSPC treatment horizons, darolutamide without chemotherapy, the ARANOTE evidence. Next slide. So these are the disclosures. Next slide. Yeah, so the standard of care for metastatic HSPC has evolved. Nowadays, that combination of ADT with AR inhibitors, abiraterone or docetaxel is the standard of care. So these are the timeline of treatment. If we see since that 2014, that the charted trial, that docetaxel plus ADT, then that the Stampede trial, then the Latitude. Next, there are lots of now that in 2024, the 2021, that the Peace One trial, abiraterone plus ADT plus minus docetaxel, and now that in 2024, that the ARANOTE trial, that darolutamide plus ADT, or ARASEC trial, darolutamide plus ADT. So despite the treatment with ARPI plus ADT or docetaxel plus ADT, a large proportion of patients of metastatic hormone sensitive prostate cancer will ultimately progress to metastatic CRPC within 3 years of time. So that is the basically that unmet need of today's treatment in prostate cancer. Next slide. Yeah. So these are the unmet therapeutic need. So basically that the needs remains for an efficacious treatment that offers an differentiated and improved safety profile for patients with metastatic hormone sensitive prostate cancer without adding significant toxicities and with a low drug-drug interactions. So ARASENS is a phase 3 study in combination with docetaxel that already showed beneficial efficacy and safety profile in metastatic HSPC patients, leading to its approval in India in 2023. So darolutamide in combination with EDIT would provide efficacy benefit with a visible toxicity profile in HSPC patients, as demonstrated in that global phase 3 ARANO trial with significant Indian patients. With the ARANO data, the darolutamide have the potential to change the treatment paradigm, as now it would be the only aromatase inhibitors, androgen receptors inhibitors, which could use with or without chemotherapy. Next slide. Yeah, so background of the study is that darolutamide plus ADT with docetaxel is the standard of care for MHSPC. In ARASENS, Daro plus ADT plus docetaxel demonstrated favorable efficacy and safety versus ADT plus docetaxel in patients with MHSPC. ARANOTE was designed to evaluate the darolutamide plus ADT versus ADT to provide a new treatment options for MHSPC without docetaxels. Next slide. Yeah, so these are the study design. So if you see that it is a double-blind placebo-controlled phase 3 study, that patients included was MHSPC, histologically or cytologically confirmed adenocarcinoma with a good ECOG performance status, stratified according to the visceral metastasis and prior local treatment, stratification according to the 2:1 randomization. Darolutamide 600 milligram twice daily plus ADT compared with placebo plus ADT. Primary endpoint of this study was recurrent RPFS. Secondary endpoint was the OS, time to initiation of subsequent antineoplastic therapy, time to progression to CRPC, time to PSA progressions, rate of undetectable PSA, time to pain progression, safety. And other pre-specified endpoint was that PFS2, time to subsequent therapy, time to deterioration of that pain, and basically that the data cutoff was 7 June 2024. Median follow-up for the darolutamide group was 25.3 months. Selected endpoint was the overall survival and safety in this study. Next slide. So these are the patient demographics and clinical characteristics. So if we see that is almost matching between the two, but important demographic characteristics was that Asian patients, almost 32% patients in the darolutamide plus ADT was that Asian patient. De novo metastatic disease was 71%, recurrent disease was 22%, high volume disease was significant. So it's very important that almost 70% patient had high volume disease. Next slide. So these are the country representations across the breakthrough clinical trials of prostate cancer. So if you see that ARANOTE study, that almost in 204 patients, 30%. So if you see that China almost 14% patient, India almost 13% patient, Taiwan, Australia, New Zealand was around 3 to 4% of patients was included. and 39% patient was from North America. Europe was 38% patients. Next slide. So darolutamide plus ADT significantly reduced the risk of radiological progression or death by almost 46% when compared to the placebo plus ADT. And if you see that hazard ratio for the RPFS was 0.54, so almost 46% reductions in the event. So darolutamide plus ADT median was not reached versus placebo plus ADT median was 25 months. And there was a persistent separation of the curve. And if we see at 2 years, almost 70% patients are recurrence free in the darolutamide plus ADT compared to 52% in the placebo plus ADT. Next slide. So these are the forest plot, and if we see that darolutamide plus ADT subgroup analysis, that each and every group that it favors for the darolutamide plus ADT. So being it an visceral metastasis, being it an prior local therapy, that racial dispositions, in each and every group that it did better. Next slide. Yeah, high volume versus low volume. So even if in high volume disease, though the low volume disease did far better, but in high volume also it did well. Next slide. So these are the other endpoints like that. If we see that the time to metastatic CRPC, time to PSA progression, time to initiation of subsequent systemic therapy for prostate cancer, time to pain progressions, in each subgroup, basically it favors darolutamide. So at the time of primary analysis, OS data was immature. Since the OS is immature, patients will be followed for survival in this trial. And all the remaining was par protocol placebo patient offered crossover to that darolutamide after the primary analysis. Next slide. So these are the time to metastatic CRPC. So if we see that hazard ratio was 0.40 for this subgroup, and there was very early separation of the curve. So darolutamide plus ADT median was not reached versus placebo plus ADT median was 13.8 months. And if we see that the symptomatic disease progression, like the time to pain progression in darolutamide median was not reached versus placebo plus ADT, it was pain progression in 30 months only and a hazard ratio of 0.72. So delays in the time to pain progression can be high importance in patients for this disease. Next slide. Yeah, so if we see that the PSA less than 0.2 undetectable at any time during treatment, it was 62.6% in darolutamide plus ADT versus placebo only 18.5%. And time to PSA progression, darolutamide plus ADT, the median was not reached versus placebo plus ADT, it was at 16.8 months, hazard ratio of 0.31. So 63% of the patient in darolutamide doublet arm attained and PSA of less than 0.2 nanogram per ml, and this represented almost 69% improvement in time to PSA progression in the darolutamide arm versus ADT alone. Next slide. A higher proportion of patients achieved undetectable PSA less than 0.2 nanogram per ml with darolutamide versus placebo in both high volume and low volume disease. So if we see that high volume disease at 24 weeks, 36 weeks, 48 weeks at in times, there was almost 50% patients achieved this undetectable PSA. Next slide. Uh, if we see that subsequent life prolonging anti-cancer therapy, that patients with subsequent life prolonging systemic therapy, that in darolutamide plus ADT, it was only 32.5%. versus 42.5% in placebo plus ADT. So out of that, 22% patient received docetaxel. Abiraterone acetate received 12.8%, 3% enzalutamide, apalutamide 1.5%. Next slide. So incidences of treatment-related adverse event was similar between treatment groups, and discontinuations were lower in the darolutamide arm. So that if you see that grade 3 or 4 adverse event in this darolutamide plus ADT was 30%. It was almost comparable between the two groups. Serious adverse event was 23% in both the groups. So median treatment duration was 24.2 months in darolutamide arm versus 17.3 months in the placebo arm. The safety profile of darolutamide in ARANOTE was independent of the PSA response and consistent with the favorable tolerability first seen in the RMS and ARASENS. Next slide. So rates of most common adverse event were low and similar between the two arms. So if you see that the fatigue was similar, so in each and every adverse events from that hematological toxicities like anemia, arthalgia, UTI, back pain, increase that liver, alter liver enzymes, hot flashes. Hot flashes was a little bit higher, but otherwise that mostly it was comparable between the two arms. Next slide. So the rates of adverse events commonly associated with that ARPIs were similar across treatment arms. So that is very important. So from that hypertension, vasodilatation, flashing, that cardiac arrhythmias, fatigue, rash, bone fracture. Bone fracture was a little bit higher in that darolutamide. So that is the class effect. Apart from that, if you see that heart failure, others like the fall, including accident, was almost similar between the two. Next slide. So ASCO 2025, that darolutamide confers a positive impact in health-related quality of life according to that FACT-P total score. So darolutamide extended median time to deterioration of the FACT-P score by 5.1 months versus placebo. And darolutamide is the first and only AR inhibitors to demonstrate clinically meaningful delays in pain progression and overall well-being. Next slide. So darolutamide doublet therapy demonstrates clinically meaningful delays in deterioration of overall well-being, especially on the social, functional, and urinary symptoms domain. So is very important that different social and emotional domains have also significant improvement in that. It favors darolutamide versus that placebo group. Next slide. So charted was that high versus low volume. Latitude was the high risk disease. Tempered RT to the prostate has OS benefit. And that peace trial was the triplet in high volume OS and low volume disease, that is PFS. And high volume disease chemo with doublet triplet was better. So this is the overall summary of that different studies. Next. So darolutamide plus ADT significantly improved that PFS in patients with metastatic hormone-sensitive prostate cancer. Darolutamide showed a benefit across all the secondary endpoints. Darolutamide was associated with deep PSA response, regardless of the baseline PSA. And this drug is the first and only AR inhibitors to demonstrate clinically meaningful delays in the pain progression, overall well-being, including the social, functional well-being, urinary symptoms. And darolutamide has a very that favorable safety profile. So darolutamide plus ADT without docetaxel should become an additional standard of care for metastatic hormone-sensitive prostate cancer. Thank you for your patience here.
Thank you, sir. Good night.
Thank you, Arnab. Good night. Good night.
Good night.
Thank you, sir. Thank you all for your nice presentations. I think we have come to the end of this today's meeting, and we do not have any questions in chat box as well. So, with all of your permission, we are closing this meeting. May I request the tech team to kindly close the meeting? Anyone from the tech team, tech support?
Yes, sir.
We have done with our meeting. We can close it.
Thank you, sir.